Good afternoon, everyone, and thank you for joining today for back to and beyond the base, really having a comprehensive understanding of base deficit and the role it plays for us in really advocating for and diagnosing our patients. And I changed the title just a little. I changed it to Stewart 101. This is in honor of Paul Stewart, and Paul Stewart was really the developer of the understanding of the role of the base deficit, as well as understanding strong ion dissociation, often referred to as SID, not SIDS like with the neonates, but strong ion dissociation. And oftentimes the equivalent is Stewart ion dissociation. One of my really excellent colleagues, a critical care nephrologist at UPMC, John Kellum, has really developed the strong ion dissociation or Stewart ion dissociation methodology and understanding so that we have a better way of evaluating patients with metabolic acidosis and not missing some of the major issues. And some of those major issues are really about albumin and they're about chloride. And so they're really important when we're thinking about the base deficit, how we're using it, what it means to us, and where we're going to go from here. So I always like to remind everyone that you should always consider in patients who have electrolyte abnormalities, in patients who present with these abnormalities, that you need to look at electrolytes and blood gases. Anytime you are choosing to evaluate electrolytes, you should always be doing a blood gas as well, because of the role that the electrolytes actually play in the balancing of the positive and negative charged ions, as we call them, the cations and the anions, and the roles that they play in gap development and gap understanding. So if we look at this list, this is not a complete list of every patient that you should consider an electrolyte and blood gas panel in, but these are patients that present to us that we must immediately be thinking about what are their electrolytes and what are their blood gases and what is the relationship, because they are so intimately and intricately related. And a lot of times we're not really looking at those relationships in terms of evaluating our patients. So I always like to remind you that depending on where you are, what relationship you have with your providers, if you're a provider yourself, that blood gases are really essential. And it's not necessary that it's an arterial blood gas. A venous blood gas is going to be a great sample for us. The base deficit in the venous sample is really, really meaningful. The recognition of the presence or absence of oxygen in the venous blood gas is really important. Now, we're not talking today about venous blood gases. I've done this before. I'm sure I'll do it again. I'll do it in a different way. But the importance of a blood gas is not dependent on whether or not you can do an arterial stick. So that's really important for us to remember. Blood gas is essential in these critical population of patients, and particularly if you first did a chem profile and you saw that your patient had some electrolyte abnormalities, it's going to be very important for you to do a blood gas. And again, venous or arterial or both, if you have that advantage. Now, if there, for some reason, you're not able to ensure blood gas, either point of care or to the lab, it is acceptable to look at your anion gap. And your anion gap will give you some very good information about the presence or absence of metabolic acidosis, except that the anion gap does not factor in some of the buffering agents, most particularly albumin. So you might have a patient who is actually acidotic, and you won't be able to fully diagnose it from an anion gap, because the anion gap may be normal, even though if you were to correct it, it would be wide and abnormal. So again, I think always really important to consider that in any patient that meets these categories, and I'm going to sneeze, I'm so sorry, or maybe not, maybe I caught it. Okay, good. So in any one of these patients who meet these categories, in patients who are unstable after initial resuscitation, in any patients that you have questions about, it's really important to consider an electrolyte panel and at either a venous blood gas or an arterial blood gas. Blood gas is really an essential part of evaluating our patient, evaluating our intervention and actually helps to guide where we're going to go next in our therapeutic perspective and how we're going to manage our patients. So really vitally important. Now, most of us have talked a lot of, if you've been with me for a while, we talk a lot about metabolic acidosis and the effects of metabolic acidosis. So clearly metabolic acidosis, not necessarily about the pH, but about the presence of metabolic acid. And that in that higher presence of metabolic acid, it has to be pretty abundant for the pH to be effective, you can have some significant metabolic acidosis without a profound decrease in your pH. So again, we kind of widen our scope as we're evaluating our patients, and we talk about individuals who have depressed myocardial contractility. Okay, so first and foremost, that might be an echocardiogram, it might be a cardiac ultrasound, but one of the easiest ways for the majority of us to evaluate a depressed myocardial contractility is by looking at the systolic blood pressure and response of systolic blood pressure to fluid resusc to inotropic administration, or a methodology for looking at stroke volume. So I don't really care how you look at stroke volume, wherever you work, whatever you do. The most primitive way would be pulse pressure, systole minus diastole, or systolic pressure. That's the most primitive, but if that's what we've got, that's what we'll do. But you can also use methodologies. You could use a flow track transducer to look at stroke volume. You could use a clear site transducer to look at stroke volume. You could use a Starling device to look at stroke volume. You could use PICO or LIDCO. You could use a PA catheter. But it doesn't matter what, don't be limited by the presence or absence of equipment. In critical patients, you need to follow depression of myocardial contractility. And that depression, myocardial contractility, will significantly affect the amount of volume that the ventricle ejects. So find a way to do it, whatever way that is, non-invasive, minimally invasive, multiply invasive, all of that is okay. You really want to consider that when we have a patient who we see as having metabolic acidosis, they had a wide gap, they have a base deficit, or God forbid, they have a base deficit and their pH is low, we're going to expect depression of the myocardial contractility, which means overall, we're going to have some trouble with their blood pressure, and we're going to have problems with blood flow. And as we have problems with blood flow, metabolic acidosis, of course, will get worse. Now, whenever you have metabolic acidosis, you're going to have a very high stimulation of sympathetic output. And that sympathetic output is seen by you, most importantly, by the coalition of persistent tachycardia and persistent tachypnea. That coalition, tachycardia and tachypnea, really does require an investigative approach to evaluate the presence of metabolic acidosis, reminding ourselves that sympathetic activity is stimulated very significantly in the presence of metabolic acidosis, and in particular in dysmetabolism, which is what causes metabolic acidosis. So our expectation with sympathetic overactivity is that you will have vasoconstriction. Now, just as a reminder about vascular tone and the ability of your vessels to constrict, not only do you have to have sympathetic activity, you must also have vascular muscle receptivity, and that is profoundly affected in the state of metabolic acidosis. So you can go from an early sympathetic overdrive with vasoconstriction to a vasodilated response because of the presence of metabolic acidosis. And just remind yourselves always that whenever you have a patient who now has metabolic acidosis by base deficit or low bicarb, signified by a pH less than 7.25, that patient may start to lose his vascular tonal response. And now you're chasing after that patient who has severe metabolic acidosis with vasopressors and volume. And typically, unfortunately, that scenario just progresses to worse. Okay, so the reason it progresses to worse is that in metabolic acidosis, you tend to have resistance to circulating catecholamines, which of course is one of the reasons that we look to hormonal therapy in patients who have metabolic acidosis. So metabolic acidosis, norepinephrine, epinephrine, phenylephrine, if you're using dopamine, even dobutamine, using that for myocardial contractility, that all of those are mimetics. They mimic the sympathetic nervous system. And in the presence of metabolic acidosis, you download your response to those catecholamines, which actually carry the sympathetic nervous system stimulation to the receptor site. And those catecholamines, norepinephrine, epinephrine, again, looking at anything that's got pure alpha or beta effects, your patient's not going to be able to respond. And so that's why traditionally metabolic acidosis, we're really quick to add in the vasopressin. We're also quick to consider a 100 milligram bolus of Salucortef. And you might also at that time be considering utilization of the third really important hormone in critical care, and that would be angiotensin 3. Angiotensin 2, I'm sorry. This is a patient issue, so let me just respond really quick. Thank you very much. Okay. So remember that ultimately with metabolic acidosis, although you've got sympathetic overdrive, you're going to end up with vasodilation. And unfortunately, exactly the opposite effect on the pulmonary vasculature. So when your arteries are dilated in metabolic acidosis, your systemic arteries, your pulmonary arteries are constricted. Now, as your pulmonary arteries constrict, you're going to have worsening gas exchange and worsening CO2 clearance, which then will just make your problem worse. So it really makes sense to try to navigate through this to protect your patient in the presence of metabolic acidosis, to try to protect your patient from this downward spiral that occurs with metabolic acidosis. Now, the other thing that's always really important, and I always like to be really, really, really careful when I'm talking about this relationship, is that one of the most important things that happens in the presence of acidosis is a shift of the metabolic acid, which is hydrogen ion, H+, into the cell and the expression out of the cell of the potassium. So actually at the cellular level, you can have very significant hypokalemia, and in the serum level, you will have an over-predicting hyperkalemia. Really, really important. So our patient who has blood pressure down and refractory, if we have a PA catheter, we're looking at the CVP, we're looking at the engorgement of the systemic bed. We just say the PA pressures are up. So blood pressure's down, PA pressure's up, got a lot of volume in the interstitium and in the venous compartment. Patient is tachycardic, he's tachypnic. You need to think metabolic acidosis. And if you haven't gotten a blood gas, again, venous or arterial or both, it's okay. You need to think about a blood gas at this junction. So maybe the patient came into the ED, and I'm so sorry, my phones are ringing like crazy, and that's kind of unusual. It's a little unusual for me to get a call on my office phone, but it's not in Grady, so I'm cool. It's probably somebody saying, hey, I need to talk to a patient on 4B. No, sorry, I'm not the operator, but thank you. So very important for us to remember that if we have not gotten a blood gas, we need one now. And again, you can use the anion gap, but the anion gap can be a little bit soft in actually evaluating a patient with true acidosis. So we just really want to be sure that we're advocating correctly when we're seeing this clinical picture, which I think we see every day in our patient population. So we've really got to consider how we're going to evaluate them in the best possible way. The tendency today is to actually order less labs and to be less invasive. And we can make some summary judgment here. Well, you've got hypotension, you're tachycardic, you're tachypnic, I think you have metabolic acidosis. But in order for me to say, okay, I'm switching completely from norepinephrine, epinephrine to vasopressin and angiotensin and Salucortef to try to bring your blood pressure up, I really need a better a theoretic structure. I need to actually have some data that really points to that situation. Now, most of us are pretty familiar with respiratory acidosis. Probably the most important thing for us to remember is with respiratory acidosis, that's a potent stimulation of ventilation, so that increases our respiratory rate, but it's also a very important component in causing cranial and pulmonary vasodilation. So, of course, what that means is as we vasodilate the cranial arteries, when we have a higher CO2, that increases the intracranial pressure. You might say, oh, I'm not that worried about it. My patient didn't have a head injury, didn't have a stroke, didn't have a bleed. But I can guarantee you that you have cared for patients. I myself have cared for patients where they had no head injury to begin with, but they don't wake up. And when we do a CT scan, we see that they have a generalized edema. Remember that whenever your vessels dilate, you have more volume in that vessel. You may have a higher hydrostatic pressure, maybe not a driving pressure, but a higher hydrostatic pressure. And as that hydrostatic pressure goes up, what can then happen, of course, is that fluid is going to creep across the vessel into the interstitium. And when you're inside of a closed vault, like the intracranial vault, inside a dural sac and a bony box, that increased intracranial pressure can cause really significant alterations. So really important for us to remind ourselves about this relationship. It's also really important, and I'm going to mention this here, I'm going to mention it again. This can be very confusing for providers. Respiratory acid is produced in cellular metabolism. So really, quite honestly, respiratory acid is a metabolic outcome. As the cells increase their metabolism, you're going to see a higher cellular level CO2. That we see that in the venous blood gas. We can see that in the venous sample. That CO2 is a byproduct of cellular metabolism, but that CO2, because it's a volatile gas. It's a gas. It's not a fixed acid or organic. It's a gaseous acid, is removed by the lung. So for the majority of us, when we talk about respiratory acidosis, we're always thinking, okay, well, this is about ventilation. And indeed, that's true. You can increase ventilation to regulate that CO2, but that CO2 increases in the aspect of good ventilation. The venous CO2 increases because of cellular metabolism. So never, in your communication with your providers and all your colleagues, you're not going to really say, well, CO2 is a metabolic acid, because the conventional wisdom is it's a respiratory acid. We regulate it by breathing, which is absolutely true. But I want you to remember CO2 is produced when you're hypermetabolic. So if CO2 production goes up, that puts an extraordinary drive on the lung to regulate that CO2, because I'm making more at the cell because I'm hypermetabolic. So what actually happens, though, is as the CO2 in the blood goes up, that's going to depress. It's going to cause more of a depression of intracellular metabolism. So by the way, ending up with a higher production of CO2. Now, with metabolic alkalosis, you can also have depressed myocardial contractility. One, with acidosis, your intracellular potassium is low, and two, with alkalosis, your intracellular potassium is high. So you, again, can have a very significant decrease in myocardial contractility. And again, that's really important to factor that into the way in which you're monitoring your patients. You may have significant dysrhythmia, significant alterations, because typically with metabolic alkalosis, you may have some cerebral vasoconstriction, so decreased cerebral blood flow. That patient will become confused to obtunded and anywhere in between, from confusion to obtundation, stuporous, etc., as that alkalosis proliferates. And you can have very high levels of neuromuscular excitability, because the internal of the cell is now actually hyperpolarized, which is really concerning and puts our patients at pretty significant risk. Okay, so respiratory alkalosis effects, they're really big. First and most important, of course, is neurologic effect. And of course, that's related to the cerebral vasoconstriction and alteration of neuromuscular irritability, cardiovascular effects with cardiac arrhythmia and depressed myocardial contractility, just like with metabolic alkalosis, and other effects, which are really, 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 really important. And what's really, really important about that is that when we neutralize the serum, either because we have respiratory alkalosis or metabolic alkalosis, and whether that's endogenous or induced, meaning I gave you bicarb or I'm blowing off your CO2, what will happen is the signal that tells hemoglobin to release oxygen will go down. And because the signal that tells the hemoglobin to release oxygen goes down, we call that a shift to the left in the oxyhemoglobin dissociation curve. Now, lots of syllables there. Hemoglobin's sole purpose is to carry oxygen and release it when it's needed. Okay. If you're acidotic, you're going to release oxygen more aggressively. That's called a shift to the right. Release, release, release. And if the signal is that the cells don't need it, if you have alkalosis, the signal is that the cells don't need it, and hemoglobin will latch on to that oxygen. That's called a shift to the left. So those are important things that happen when we have deregulation. But our purpose here today is to really talk about base. And what is the meaning of base? When we look at base in relationship to only metabolic events, base is not a reflection of respiratory regulation. It is a reflection of metabolic events. So we have to remind ourselves that acid is really carried in two basic components: as a gaseous acid, CO2, and as a fixed acid, hydrogen ion. Okay, so that's really simplified. It's much more intensive than that, but it brings us to appreciating the base measure. Why we go back to the base, why the base is so important. What is it that's beyond the base that really informs us about what's occurring with our patients? So first and foremost, we just remember about ions. Ions are particles that actually, when dissolved in solution, release or accept hydrogen, basically. And they're acids or salts. So they're cations, positive, anions, negative. Stronger electrolytes and weaker electrolytes, meaning more likely to dissociate or ionize, and less likely to dissociate and ionize, all of which is beyond what we need to fully investigate here, but just have an understanding about that importance of the electrolytes. And then, of course, the metabolic acid. And all of these things, the cations, the anions, strong electrolytes, weak electrolytes, and acid donation, acid production, and acid regulation all affect the pH. And I can only know about the pH, really. pH is the symptom, but I can only really know about the pH if I do a blood gas, which is why blood gas is so incredibly important. So if we just think about our basic ions, the ones with the positive charge and the ones with anions, the ones with the negative charge. So this isn't everything. This is not a complete list, but these are the ones that we talk about most commonly in our critical care practice. We talk about sodium, positive charge, potassium, positive charge, calcium, double positive charge, magnesium, positive charge. And then we talk about our anions, and these are the ones we measure, right? These are the ones we look at almost every day when you're looking at a chemistry profile, but maybe you're only saying, does potassium need to be repleted, but not really thinking about the role of potassium in the acid-base balance and what kind of effect it has on your base deficit. Our anions, or standard ones, are phosphorus, bicarb, and chloride. So you can see it's pretty easy to see the difference. One is positive, the other is negative. They are not electrically neutral. And it's really important to remember that in order for them to be electrically neutral, they have to either lose an ion or accept an ion, right? So sodium has to lose one positive to become neutral, not positively charged, right? Now, here's the one you don't talk about, but from our point of view, especially when we're talking about base deficit, what's really, really important to us when we talk about base deficit is really recognizing the role of the hydrogen ion. The hydrogen ion is so incredibly important. That's what really exerts the effect on your pH. And this is called a logarithmic or negative logarithm effect. As hydrogen goes up, pH goes down. As hydrogen goes up, you're more acidotic and your pH goes down. Now, the role really of these anions, and phosphorus is at a very low level, it's mostly bicarb, number one, number two is chloride, is to accept that ion, that hydrogen ion that gets donated in the serum. And when chloride marries hydrogen, it's no longer chloride. When bicarb marries hydrogen, it's no longer bicarb. And that's what's so important. Well, most folks would say, well, Barb, we don't really measure hydrogen ions. I know that. But I want you to remember, you do measure pH, and you do measure bicarb, and you do measure base, all of which are reflecting the presence or absence of hydrogen ion. So all acid solutions, of course, have a low pH, and they have to have a high concentration of hydrogen. You can't be acidotic without that. So acids that are suspended in water donate hydrogen ions, okay? So acidotic solutions, conversely, have a very high concentration of hydrogen. So that's a really important concept to remember. You don't measure hydrogen, but you're going to think about the strong acids in our circulation that when dissolved in water donate hydrogen ion. Now that hydrogen ion fluctuates a lot every minute, every hour. But the issue is, do we have enough base to buffer that? And are we able to excrete it from the kidney? Because that's how you get rid of hydrogen ion. So that's really important. So why not measure hydrogen ion? Because that's really what we care about. The pH is a symptom of the presence or absence of hydrogen ion. Hydrogen ion is up, pH goes down. The advantages are, this is what we're used to. That's what we've always done. It's really hard to measure hydrogen ion. You need very specialized equipment. We have easy ways to measure pH by a pH electrode. And oftentimes in a lab, measurement of hydrogen ion is not going to be correct because really we're not just looking at the presence of hydrogen, but its effect on the pH. So this is why we primarily measure pH. Okay, it's a really important thing. The other issue is that we're so embedded into understanding when pH goes down that you're acidotic. It would be a very hard transition to say, oh, hydrogen ion is up, you're acidotic. Because H plus, it's up. How could that be acidotic? How could that be a bad thing? So it really is mostly conventional wisdom and the limitation of our equipment. But we can actually quantify. So this is a really simple tool everyone can use at their bedside. That is that at a pH of 7.4, you have a hydrogen ion concentration of around 40. For every 10 increase in hydrogen ion, so from 40 to 50, you'll drop your pH 1 point. So when I see a patient who's got a pH of 7.2, I know that their hydrogen ion concentration is right around 60 or 65. Now, nobody's asking you to do math or memorize. All I want you to remember is that for every 10-fold increase in hydrogen ion, and that's in terms of the millimoles, your pH will go down. For every 10-fold decrease in your hydrogen ion, your pH will go up. Now, remember, we really think about three major compensatory defense mechanisms. Buffering, that's the most important one. That's the first one. It happens immediately. It's really important. Buffering, using your bases. Lung excretion and kidney excretion. These are the three important defenses. That's why I always say you're charting. I went and looked at a patient yesterday in the emergency department here. He's been in the ED for about 12 hours. He's admitted and being managed by the medical surgical team. They're doing a great job. Patient, though, consistently is breathing 25, 26, 30 times a minute. You got a patient who's tachypnic, and we look at his x-ray, and his x-ray looks clear. His SAT is acceptable, but he's tachypnic, and he's tachypnic over time. That almost always points to a compensatory mechanism for metabolic acidosis. And you can't know it if you're not measuring it. So we have to really think about how to advocate early on to actually look at our patient's blood gas. We care a lot about pH. pH is a symptom. And then we care about the two components to pH, and that is the regulation of carbon dioxide and the regulation of hydrogen ion. So first and foremost, just to remember, you can basically quantify the hydrogen ion by having just a simple rule. For every degree down, you've increased hydrogen ion 10-fold, okay? And you can see that here, that as the hydrogen ion increases, and as it increases in terms of content below 7, that is a rapid increase. When hydrogen ion increases, is a rapid decrease in the pH. So you have a really stiff up of the curve as your hydrogen ion goes up and makes your pH go down. So very, very important. Okay, and we're really talking about causative, not compensatory. So again, we don't measure hydrogen ions, right? So 40 millimoles is what's normal. We don't measure hydrogen ions. We do measure the pH. pH isn't measured in units, just standard. It's just a pH stick. And we want to remind ourselves we don't look at hydrogen, but what we look at is its opposer. And its opposer is base. Now, base is a calculation. So that's important. Sometimes I have doctors say, well, I don't like to look at base because it's a calculation. You haven't got anything better. You really have to look at base. Bicarb's a calculation too. Everything is a calculation. But when we look at base, what we're actually supposing is how much buffering capacity had to be encouraged in order to neutralize the presence of acid. So we know that whenever you have an increase in hydrogen, you will have a decrease in base. That's why the base is so important. Base deficit means acid excess. And more specifically, I should be clear, metabolic acid excess. Base deficit always equals metabolic acid excess. So we don't measure hydrogen. We do look at pH, but we need to have a clear view on what it means to look at a base deficit. Now, some labs don't use base deficit. They just use bicarb. Well, that's okay. So you're using one factor and it's calculated. Bicarb is calculated. Base actually incorporates other buffering capabilities into the calculation. So it gives us a more specific view of the presence of metabolic acid. So that's a really important concept to us. Okay, so just to review, the terminology is that pH is a negative logarithm of hydrogen ion. I hate those terms, negative logarithm. It always feels very off-putting to me, but all it means is the opposite effect. Hydrogen goes up, pH goes down. Hydrogen goes down, pH goes up. That's all. It's the opposing effect. The presence of hydrogen makes the pH go down. And that doesn't seem natural because if pH is the presence of hydrogen, pH, presence of hydrogen, you would think that as hydrogen went up, pH would go up, but that's not true because, of course, hydrogen is an acid. Now, when we talk about acids, things like, and I'm going to review this multiple times, when we think about things like lactic and we think about ketones, these are acids because they donate a hydrogen ion. So when I measure lactate, I'm not measuring acid, I'm measuring the presence of lactate. And as lactate goes up, that means naturally that more hydrogen ions been donated into the blood. As ketones go up, that means naturally that more hydrogen ions have been donated in the blood. So I want you to remember that we have strong acids, we have weak acids, we have those that dissociate or ionize and those that don't, that all we want to remember is acids, and in particular acids that we care about in our practice, lactate and keto acid, those donate hydrogen ion. So whenever they're up in presence, that means you have a lot more hydrogen ion. Now, because your hydrogen ion went up, that has to be accepted by a base. A base accepts that hydrogen. That the purpose of the base accepting the hydrogen is to neutralize the presence of hydrogen, which also means neutralizing the pH. How straightforward is that? It's so straightforward. So when I look at your blood and I see that your base is low, that automatically means to me that you've been accepting hydrogen, because when base marries hydrogen, it's no longer a base, right? Now it's an acid because it's got a hydrogen on board that it can donate. So really, really important to remember that the simplicity between acid and base is whether or not you have a hydrogen on board. When you have a hydrogen on board, you're an acid. When you can accept a hydrogen, you're a base. The thing is that when you marry metabolic acid hydrogen to a buffer, it becomes a weak acid. Hydrogen is a strong acid, but when it marries to a base, it becomes a weak acid and has much less of an exertional effect. Okay, so again, I want to remind you about ions. When we talk about ions, those are really related to the electrolytes. And they are salts that just break down in water. They have electrically charged ions. The cation is positive, anion is negative. And in a homeostatic state. Everything is right, everything is equal. Cations equal anions, meaning that positives equal negatives, and then there's just no movement because there's equality there. And they, of course, are commonly measured here in the United States in milliequivalents. So just remembering about the cations and the anions, and I added 2 anions here that were not on your prior visual, and that would be sulfate and protein. And protein, again, remember the role of albumin in terms of buffering capabilities. So really, really important, looking at their presence in the interstitium and intracellularly, and really recognizing that we neutralize in the interstitial fluid or in the plasma, and we also neutralize inside the cell. And remember, perfect hydrogen content. So these are the Stewart players, and the Stewart players, the strong ion dissociation is about our electrolytes, our non-volatile, those are called fixed acids. That would be most particularly hydrogen ion and CO2 as a respiratory acid. These are really going to affect our pH. They're going to affect our hydrogen ion content. They're going to affect our bicarbonate, and lots of different reasons that they're affected. So really much greater minds than mine, much greater minds try to grasp this brilliant concept of Stewart. It's a difficult concept. I just want to remind you that anion gap that comes back on your chemistry, the anion gap as it's associated with the base, the anion gap in the meaning of what occurs for your patients is really profoundly, significantly important. And so here you're looking at a true, this is the strong ion dissociation, which is the true gap, which is sodium plus potassium plus magnesium plus calcium added all together. And then chloride plus lactate and bicarb. Okay, but that's not what we do. What we do is a basic anion gap. I'm sorry, I put the parenthesis in the wrong place. So sodium plus potassium in parentheses minus chloride plus bicarb, and you really should include lactate. Okay, so that's the anion gap that you get back from your lab, is telling you about the presence of measured positives and measured negatives. Hydrogen, so this is the positive. Hydrogen is not measured, but it makes the positive side go up. And when the positive side goes up, particularly with hydrogen, hydrogen binds to the bicarb, making the bicarb go down. That's what gives you a gap. Measured, sodium and potassium. Unmeasured, hydrogen ion is up, bound to the bicarb goes down, and the gap gets wide. The anion gap is one of the most important tools that you can use, particularly if you don't have a blood gas and you can't look at a base. It's going to give you really great information. Now, there's something else called the Anion Gap Corrected. Again, I don't want to overwhelm you with math and a lot of things that I think are really important, but you might not be using at the bedside. Just to remind ourselves that albumin is a major protein component of base. It neutralizes acid. So sometimes I have a patient on a chemistry profile who has a relatively normal gap, but they're tachycardic, they're tachypnic, their blood pressure is unstable. In those patients, I'm going to go back and look. And what I'm going to do is a corrected gap. A corrected gap, AJC, is the anion gap divided by 2.5 times reference albumin. That means whatever your lab says is normal, like 4, minus the patient's albumin. So 2.5 to the reference albumin minus the patient's albumin, and then take that and divide it into the gap, and then add that number back to the gap calculation. Now, I'm not expecting you to do this. I'm not really expecting you to be too worried about it. What I want you to be concerned about is when you're looking at a patient who, by all intents and purposes, looks like, behaves like they have metabolic acidosis, but what you have is a normal gap, you need a blood gas. That's a time to say, my gap is normal, but here's the only thing I have to say, the albumin is down. And if the albumin is down and the gap is normal, then the probability is your patient has a metabolic acidosis that you're missing by your chemistry. And that's why you're going to want to take a look at your blood gas. Okay. So I just like to show this, and not necessary for me to go all of this, but I want to just talk about buffer pairing. These are the buffers. These are the things that have negative charges or the capability to accept a hydrogen ion. And once they have accepted the hydrogen ion, they become something else, okay? So they become now a hydrogen donor, right? So they've gone from being a base, which is an acceptor, to an acid, which is a donator. It's so bizarre how your human body works, and so amazing that it works so effectively. But here's the thing that's really important for you to see is that when you're looking at bicarb or you're looking at base, and bicarb goes down and base goes down, and you want to remember Rome or some other amalgam that helps you, and that's okay, whatever you need to do. What I'm concerned is that you really understand that the absence of bicarb always means the presence of hydrogen. Bicarb goes down because it accepted hydrogen. Once it accepts hydrogen, it's no longer recognized as bicarb. It's now carbonic acid, H2CO3. Now, I love H2CO3. You know why I love that? Because that can be delivered to the lung where it can dissipate into, you got it, H2O and CO2, and I can blow that CO2 off. So really, really important for us to remember that CO2 is a component of how we regulate our acid, but the truth of the matter is it's all metabolic acid. It's just the way in which we excrete it and the way in which we buffer it. And whenever you see bicarb is down, that always means acid is up. When base is down, acid is up. When bicarb is down, acid is up. Bicarb and your other buffers accept the metabolic acid and they become something else. They transfer from being a base because they took that hydrogen to now being a weak acid. So remember this purpose. Hydrogen is a strong acid. When it binds here, it becomes a weak acid and it has much less exertional effect on your pH. So I think we've already covered all of that. I just want to remind you that metabolic acidosis happens every day under your care. And what you want to remind yourself of is the main conditions that occurs, right? I can't excrete hydrogen. I've got to have good kidneys to excrete hydrogen. So if I have any stage of kidney dysfunction, I'm going to have impaired excretion of that metabolic acid, hydrogen. Ingestion of hydrogen or other drugs that are metabolized to acids that can, of course, also cause acidosis like ethanol and other agents such as that. Okay, increased production of hydrogen. This is the big one. Glycolysis. So that means in any patient who's breaking down glucagon, any patient who has high carbohydrate metabolism, any patient who's breaking down fats, ketosis, and any patient who is metabolizing at a rate that exceeds the available oxygen. And that, of course, is anaerobic metabolism. So really critically and profoundly important. Now, reduction by carb concentration typically occurs when we talk about somebody who's got impaired kidney dysfunction, also impaired liver dysfunction. So they don't have normal bicarbonate concentrations. So now let's apply that to Stewart. And this is a little intense, so don't get too lost in it, because this is what brings us to really looking at our base deficit and understanding strong ion dissociation or Stewart ion dissociation. Words that you never, ever have to say. You just have to say base deficit. That's really all you need to think about. But just reminding ourselves that CO2 is a formula from hydrogen ion. It's a production of tissue level metabolism. It's carried as a respiratory acid, and the regulation of that relies on one thing only, and that is, are you breathing fast or are you breathing slow? That's it. So the beautiful thing about CO2 is in your mind, knowing that that's a metabolic output product, but the regulation of it is the only thing we ever talk about. We just talk about the regulation of CO2 by hyperventilation or hypoventilation. Fantastic, gorgeous, done, happy, over. Okay, then we go to things that are not quite so obvious. So first of all, this is part of the total anion. That's what atot means. That when you have low albumin, you're going to have higher, you've got higher acid. That acid bound to the albumin is low. Okay. If you have a pathologic decrease in albumin, you will have some level of metabolic acidosis because albumin is required to buffer. And remember, that's part of your base calculation, but albumin is required to help buffer the acid, right? Higher levels of phosphate or actually can also cause this high total anion, and things that cause hyperphosphatemia, in particular, things like renal failure or high hyperparathyroid, usually linked to hyperthyroidism, tumor lysis. Those patients are going to have a very high level of phosphate, and that phosphate isn't actually in a natural state, and it typically is used in acute phase proteins. Okay, now here's the one that really affects you the most at the bedside. Certainly you need to look at phosphate levels, you need to look at albumin levels, be really aware of those two when you're looking at a person with metabolic acidosis, be aware of them in strong ion dissociation. Base is a calculation, so it's not an exact measure. So you also can engage with yourself, looking at your chemistry, at what your phosphorus level, what your albumin level is. Here's the other one, and I talk quite a bit about this one. I talk a lot about chloride, okay? And really, really, really important for us to appreciate that chloride is part of the anion, and that we can lose chloride when we're vomiting, when we have gastric drainage, when we're using diuretics. We can lose chloride when we are sweating profusely, when we have diarrhea. And that chloride loss actually must be balanced by a bicarb gain, or it's going to be problematic. Now, the other problem with chloride is when chloride goes up. And that's what happened to us. And we became very knowledgeable about this when we were administering sodium chloride, which immediately dissociates into sodium and chloride. And that chloride actually displaces bicarb. And you'll remember that when I was talking about your base, the number one most important base is the one that accepts hydrogen and converts to carbonic acid, and that's bicarbonate. So our goal will always be to try to get bicarb into a natural normal level, not necessarily by administering bicarb, but by looking at the conditions of the patients that are causing bicarb wasting or chloride retention. And one of the reasons that we don't use sodium chloride quite so aggressively anymore is because sodium chloride often caused hyperchloremic metabolic acidosis. Okay, really, really important. Now here we're just talking about the strong ion gap, and that's taking in all of the ions. Remember, when we're looking at all of the ions that we aren't actually measuring or calculating on when we're looking at our base, we just want to consider that in the process of our patients, looking at all of those ions. And I do want to remind you about these really strong anions. And remember, they're acids. They were acids. They donated hydrogen ion, the two really important ones that we see every day, ketosis and lactate. And the elevation of those means donation of hydrogen ions. So and they're not considered normally when we talk about our base. We don't normally talk about that role. So I want to make this as really straightforward as possible. It's very intense as a topic, but it's such an incredible importance in the bedside practice that we have every single day. Okay, so just remember, you have two types of acid, right? You have volatile acid, that's gas, CO2, and that's excreted by the lungs. If you're excreted by the lungs, you're a gaseous acid. That's it, done, been there, done that, all finished. It's the acids that are fixed. Those are the ones that are not excreted by the lungs, so they're fixed in the body. Those fixed or non-volatile acids, what I want you to remember are hydrogen ion. That's the only one you really care about, hydrogen ion. And you want to remember that hydrogen ion is increased when you have incomplete metabolism. So we have incomplete metabolism when we have glycolysis, when we have anaerobic metabolism, when we're metabolizing fats, and when we're metabolizing proteins, because we release sulfate and phosphate when we metabolize proteins. So just think about your patients who by day 5 are not adequately tissue oxygenated, they don't have adequate blood flow, and they don't have nutritional support. So really, they're breaking down in all 4 of these categories and producing more metabolic acid. So nutritional support is a really important concept here to actually protect your patient from these breakdowns of fats and proteins. And for most of us, I hope you know that when you put someone on continuous insulin, you must give them glucose, or else they will go to ketosis or ketolysis in order to produce enough fuel to maintain themselves in the presence of insulin. That's why you always use a D5 source whenever you're on a continuous IV insulin. Okay, so again, what I want you to remember is that lactate dissociates hydrogen ion. So for every increase in lactate, I'm talking about every molecule increase in lactate, not gram or milligram or milliequivalent of any of those. But every molecule donates a hydrogen ion. So it's really important that when we understand that when lactate is up, more hydrogen is donated and your pH will go down. When ketones are up, more hydrogen is donated and your pH will go down. Again, you're not measuring hydrogen, but you're measuring everything about it. You measure bicarb, you measure chloride, you measure lactate, you measure ketones. These are all about hydrogen ion and all about the base. All about the base. Okay, so back to the base, back to the base. Really, really important when we go back to the base is that we remember when we go back to the base is not affected by CO2. So it's a unique measure. pH is affected by CO2 because CO2 actually is about hydrogen. Base is not affected by CO2. And therefore, I'm going to look at these two things completely differently. Presence or absence of CO2 and its effect on the pH. Presence or absence of base and its effect on the pH. So really, really important. I always like to say when we just think about hydrogen, marrying bicarb, travels as carbonic acid and dissociates into water and CO2, and you're going to blow that CO2 off. But in the beginning, it was all about hydrogen. It was all about metabolism. It's just the transport here as carbonic acid. And when it reaches the lung, the dissociation to H2O and CO2 so that we can regulate that CO2. So that's really critically important because when I see someone who's breathing fast, I know that they're regulating their CO2 and that their CO2 production is up because they had a higher rate of metabolism. And I'm now going to be all about what I can do to help control them metabolically. So it's not just going in that room and increasing respiratory rate and tidal volume to blow off CO2. You have to step back from that and say, what is happening at the cellular level that I am increasing more acid? And I'm going to look at my base, and I'm going to look at my CO2, and then everything that I know to do about maintaining tissue perfusion and supporting the tissues is what I'm going to apply to my patient. Okay, so here comes the base, right? First defense, buffer with base. Second defense, regulate the arterial CO2. And third defense, alter in hydrogen ion, bicarbonate conjugation and excretion. Okay, so if we look at that and we just say, okay, we've got interstitial fluid, blood, intercellular, urine, and bone, and the components in here. Again, I want you to see first component, bicarb for ISF, bicarb for blood. Really, really important. And that's why we like bicarb. We look at bicarb. Bicarb is a good indicator. It's not end all and be all because there are many other buffers, right? Albumin, phosphorus, sulfate, hemoglobin, all of the ammonia are all buffers. None of them are as important as bicarbonate. So if in your institution, your practice, you're all about the bicarb, that's fine. At Grady, we don't measure bicarb. We measure total serum CO2, which is bicarb. So on my chemistry profile, my total serum CO2, which is not exerting partial pressure, it's not dissolved. Total serum CO2 is reflecting the bicarb. That's on my chemistry. Anion gap is representing the presence or absence of hydrogen ion in general, not always, in general. And base deficit tells me about the absence of buffer because of the presence of acid. Base deficit always means metabolic acid excess. Always. Doesn't tell you why, just that you have a metabolic acid excess. Oh my God, that is just so critically and profoundly important. Now, we see, again, is what I've already mentioned, is that bicarb, both in extracellular fluid and intracellular fluid, bicarb is one of the most important buffers, which is why many folks have just given it up to measuring bicarb and they don't even look at base. And remember, they're both calculations. They're both calculations. Okay. But I do want to remind you in the intracellular fluid that the cell neutralizes hydrogen ion by exchanging for sodium, meaning taking hydrogen in and excreting sodium out, and by the exchange for potassium, meaning the cells take potassium in and excrete the hydrogen out. Okay. That's really important. And if that's combined with renal dysfunction, I'm not going to be able to excrete that hydrogen ion. I'm going to plummet into profound metabolic acidosis. Okay, so hydrogen ion regulation, chemical buffer, CO2 elimination, bicarb elimination. Chemical buffers, your responsibility is to look at the base. The base is telling you about the adequacy of your chemical buffers. Whenever you're in deficit, you are not adequate. You now have free metabolic acid promoting a drop in the pH. CO2 elimination, controlled by the lungs. Remember, what's happening in the lungs actually is a response directly to the presence of hydrogen plus bicarb, that made a carbonic acid, which then dissociates into water and CO2, and I blow that CO2 off. And this one, the first chemical buffer happens immediately. The second one happens within minutes. The third one, which is bicarb elimination or hydrogen ion elimination, either one, takes hours to days. So renal compensation, not really a great compensatory mechanism. It takes a lot of time for that to occur. So again, I'm going to go back and say metabolic acidosis measured by buffers, measured by base. A bicarb deficit, meaning your bicarb is less than 22, hydrogen ion is up. You've got metabolic acidosis. A base deficit, meaning your base is more negative than -2, means that your hydrogen ion is up. You've got metabolic acidosis. Because you made too much acid, because you can't excrete it, because you've lost bicarb, because you have anaerobic metabolism, you're ketotic, you have lactic acidosis, all those things, that's the production, right? The accumulation of acids. All those things promote metabolic acidosis, which will be measured by you by a base deficit and a decreased bicarb. The buffer systems, those beautiful buffer systems, right? Taking up that hydrogen or releasing hydrogen as conditions change, which is why you are both a donator and an acceptor, because that's going to change every minute. I need more acid, I need less acid, I need more acid, I need less acid. Buffers are a base plus a strong acid. That strong acid is hydrogen. That's what the base is. It's so fantastic. It facilitates neutralization of the pH. Okay, really, really, really important. But as we overwhelm that system, your base will drop, your bicarb will drop, and your gap will widen. All of these things you can look at very simply and actually talk about. I have a patient with persistent metabolic acidosis. No wonder norepinephrine and epinephrine aren't working. They have metabolic acidosis. What can I do? How can we change this? Can we change drugs to use drugs that don't require a homeostatic pH, like vasopressin, which I think you probably already do, Salucortev, which sometimes you might do, and angiotensin II, which probably rarely you do. But I should be discussing that in the face of refractory hypotension with metabolic acidosis. So just in case you don't remember, a base deficit below -2 is metabolic acidosis, and a base excess above +2 is metabolic alkalosis. Do not call a negative number a base excess. It's not an excess, it's a deficit. Language is important. Say it right so we do it right. And it's really important to remember that persistent metabolic acidosis is a predictor of a significant mortality risk, 2 times mortality or even higher when we're talking about patients with metabolic acidosis under our care. We love the base. It's, you know that song. It's all about the base, go pH, all about the base, oh cellular. Really important to remember the importance of the base. Always important to use that base to communicate to drive intervention, to evaluate what's occurred and how our patients are doing. Really important to remember, the more deficit the base, the higher the mortality. This is a very stringent, profound predictor of mortality. But I think it's really important to say, I'm going to try like crazy, never to let my patient's base deficit get greater than -9. Now, sometimes patients come to us and they've already got a base deficit of -15, and everything we're doing is about getting them back from that. But base deficit is correlated to severity of metabolic acidosis and therefore is a mortality predictor. So we might not measure hydrogen, but we're always going to assume it. Remember, we're going to assume it by your pH. Your pH is down. And this is not a CO2 problem. It's a hydrogen ion problem. Your potassium is up. We always have to consider that you might have metabolic acidosis. We look at a wide anion gap. And of course, we look at a decrease in bicarb or base deficit. I'm going to close today with a wonderful quote from H.L. Mencken. He says, life is a struggle, not against sin, not against money, not against power, but against hydrogen ions. And I added in there, and COVID. He obviously doesn't live in 2022 where life is a struggle against sin, power, money, guns, COVID, and hydrogen ions. But I hope that this has unveiled some secrets to you, things that can assist you in doing the excellent care that you do every day at the bedside, and always reminding ourselves that what we do really does matter. How we talk really matters. What we say and the words we choose drive clinical practice, and it really matters. Thank you so very much for joining me today. I'm going to say goodbye for now.